Compassion is not prescriptive. It is spontaneous, and it really depends on the particular occasion that one is encountering, which is a very different view of compassion than the sort of common view.
This season, Ripples, Physician Wellbeing will focus on the theme of facets of compassion. Compassion for self, others, and society. The Long School of Medicine Office for Graduate Medical Education utilizes a compassion course to combat feelings of imposter syndrome, guilt, or shame with challenging patient outcomes, as well as teaching mindset adjustments to promote higher self-kindness. For each facet of compassion, we'll provide you with an episode about recognizing when an instance can require grace and the pebble to activate it. We're happy you're with us. Let's create some ripples.
Thank you so much, Jenny. It's an honor to be here. Thank you both so much. And I'm really grateful to share a little bit on your podcast Ripples and to be a pebble. Yes. Hopefully there will be some ripples. In 1970, I was working at the University of Miami School of Medicine as a medical anthropologist, working, as a consultant, support person in all of the departments. And what was very clear to me at that time, and I think it continues, is that the most marginalized population in this huge county hospital, Jackson Memorial, were people who were dying. The encounter with mortality and with the qualities of suffering that dying people were going through happened to be very challenging. not only for medical students, because this was, of course, the county hospital was the kind of context where the medical training was happening, but also for clinicians. And I saw how clearly important it was for there to be a balance between what we know as equanimity and what we know as compassion. But knowing what equanimity is and knowing what compassion is, not necessarily accessible to everyone. By equanimity, we mean, our capacity to maintain balance in the midst of very challenging conditions, of holding all things in equal regard, of having the ability to uphold oneself in the midst of conditions. And then compassion, of course, is this non-transactional sensitivity that allows us to feel concern about the suffering of others with the commitment to do what we can to benefit others. And the relationship at the somatic level between equanimity and compassion is consequential, because actually equanimity without compassion can be a little cold. And compassion without equanimity is not actually compassion.
Wow.
And we come to understand through this somatic perspective that it is important for us to develop the deeper qualities associated with equanimity and compassion so that they can arise interdependent in our own experience. And this is a key to, actually, from our point of view, clinician well-being, being able to sustain the kind of work that clinicians encounter day after day, and not have, instead of a strong back and a soft front, equanimity, compassion, a strong front that is a very defended approach to individuals, and a soft back, one that is associated with fear.
Yes, how powerful that is. It's a reminder for all of us
Yeah.
day in and day out. Thank you.
And piggybacking on that, Roshi, you also created this training specific for physicians called GRACE. Would you tell us a little bit more about that?
Thank you for asking that question. Well, over the years, by the way, I'm 82 years old, so I do have a long life behind me, and I'm grateful that I'm still here and feeling very healthy and engaged. But, I've been in this end-of-life care field since 1970, so that's 54 years. And so I've encountered not only and come alongside many, many dying people, but now thousands of clinicians who are in the field, and also family members and allied healthcare professionals who work with dying people. And in the 90s, I was appointed as a visiting scholar, the distinguished scholar at the Library of Congress. And it gave me this extraordinary opportunity to actually step out of my teaching position here at UPIA, go to DC, and to sit in the Jefferson Library for a number of months doing research on compassion. Now, this research had been a very important part of my life for about 15 years because of my relationship with social psychologists and neuroscientists. And as a long-term contemplative, I knew that, there were many contemplative approaches to training people in compassion. But honestly, training Western people in compassion and Western clinicians is not as easy a job as it might be in Tibet, say, for example, or India, or Thailand. And so my concern was that as someone who worked with dying people and with clinicians, that there was a serious deficit of compassion within the medical system, which was in a way against the grain of the experience of why people got into medicine in the first place. And that deficit not only affected patients, but also affected the clinicians themselves. Yeah. So I began to work on a heuristic map of compassion, mapping out what compassion was, because I felt that it was too associated with religious things. It was kind of fuzzy. and that it was important to understand what actually the valences were that were in the inner structure of compassion. And I discovered that compassion is composed of non-compassion elements. And those elements are trainable, and they include intention, prosociality, insight, and so forth. And I worked with various social psychologists and neuroscientists in the development of this map, and so that it was grounded deeply within the contemporary neuroscience research field. And then I realized it was important not only to have the map, of course, but it was important to have a tool.
Yeah.
And then I developed this particular intervention, which has various names, but you know, it's most commonly known as GRACE. It's an intervention that you can deploy, so to speak, as you're interacting with those who are suffering. And it's called GRACE. And the G of GRACE stands for gathering your attention. The R of GRACE is recalling your intention. The A of GRACE is attuning first to yourself and then attuning to others, which is the experience and the attunement to others of empathy. Wow. And the C of GRACE is to consider what will serve. The E of GRACE is engaging and then ending. And each of those components in the training program that we developed they're a kind of world unto themselves. But it's the interaction of these components that produces the emergence of compassion as a complex dynamical process that is completely context dependent. In other words, compassion is not prescriptive. It is spontaneous, and it really depends on the particular occasion that one is encountering, which is a very different view of compassion than the sort of common view.
Thank you so much. I think that is wonderful.
So wonderful, and I think a really powerful practice for clinicians if they really work with it. Thank you so much for making that, because I think it is just amazing. So Roshi, one of the articles that I provide to the residents that are taking the compassion course is a beautiful piece that you wrote in the fall of 2020 about equanimity and grandmother's heart. Could you tell us a little bit about Robashin and grandmother's heart?
Yeah, it's a wonderful term in Japanese. Actually, it was my good friend Kazuaki Tanahashi who shared the term with me. And it means grandmother's heart, as Jenny has said. And it refers to this kind of wisdom that you can encounter, particularly in old women, but also really any gender, any age. And it is this experience of kind of depth of perception, where there's balance, where there's a kind of understanding about the truth of impermanence, that nothing that we experience is fixed in time or space, a sort of radical patience, a kind of natural kindness, but kindness that also can have a fierce valence. You're just not a rug that people are stepping on. Yeah. And also the capacity to meet situations in a way that is very fresh and very new, because you have engaged a kind of curiosity. So, I know old people like this, and maybe I'm a little bit like that myself, in the sense that my own experience of working not only in the end-of-life care field, but on death row and maximum security, the penitentiary of New Mexico, or working in the Himalayas, in these high-altitude villages which have no access to health care at all, and being, in very complex situations, the experience that one has in the course of a lifetime gets digested in good circumstances in the nervous system in such a way that one is able to respond with a kind of naturalness, and doesn't experience trauma, doesn't experience aversion or fear, when in the midst of very complicated situations.
Oh,
Thank
what a
you.
beautiful
Yeah.
concept. We all aspire to be one, at
Yes.
least work towards that. Thank you for bringing that. My question to you is, this is one of the greatest challenges for all of us, is to show compassion for people who don't look like us, or who we instantly judge, saying that, oh, this person is in handcuffs, or this person is not well dressed, and we make this judgment. How do we show compassion to people who are not like us, or who we think that we don't need to show compassion?
This is such a beautiful question. And in a way, this question was very much in my foreground around a politician years ago whom I felt was engaging in egregious harm of others. And, so I had a certain amount of moral outrage. And also, as I was a young woman in the 60s. So let me tell you, I was on the front lines of the civil rights movement and the anti-war movement. And then I've been working in environmental protests over many decades. And, kind of moral outrage has been a sort of companion of mine for a long time. And othering. And that othering process is a process of dehumanization. And it not only dehumanizes others, but it also dehumanizes ourselves. Mm-hmm. And I recognize that both in my work with dying people, also in relation to my aversion to certain politicians, and not just our national scene, but I'm talking about globally as well. And also, in working in the end-of-life care field, that I had, at a very preconscious level, engaged in the kind of alienated perspective that othering produces, because I didn't feel safe with certain people, as you can imagine. With the prisoner on death row, with a homeless person who was inebriated and threatening, or with a dying person who was raging around the encounter with their own mortality. And I had to look deeply at my own experience, but also I sat with so many people over the years. I had a big N. N means, a big number for my personal research, and, sitting with people who were extraordinarily dysregulated. And what I recognized that was so important is that the states of mind that are threatening to us as others experience them are actually suffering it themselves. Those states are suffering. The politician who is racially or misogynistically disparages, the prison guard who humiliates, the doctor who objectifies her patients or his patients, and so forth, that those states of mind also are suffering. Yes. And that shifted my whole life in a very fundamental way. I saw it in my direct experience, not in observing others, but in really being radically self-honest about what was going on in myself. And as a result of that, I began this process of what John Paul Lederach, the renowned peacemaker, has called rehumanization. Even though my rejection of others had been more or less subtle and in certain ways not even obvious to me, and someone who's been through a lot of therapy and so on and so forth, I still didn't pick up my biases because they were preconscious. Yes. But when I began to dig more deeply and to realize that I was engaging in this kind of objectification of others and then rejection of others, and when I saw the suffering associated with the states of mind that were threatening to me, I began a very powerful process of internally shifting and understanding the valences of suffering, not just the kind of attractive, terrible suffering, say, a dying person is experiencing, where they're not projecting their anguish on you so you feel safe, but all of the many valences associated with others who abuse others, where you could actually feel disgust or threat or hatred or aversion, rejection, or even numbing. And when I began to understand that that too was suffering, when I looked at it deeply in terms of my response, my internal landscape changed. And also my resilience opened up, my capacity to actually embrace more difference and to include more into my experience.
Wow, that's so beautiful. And perspective taking is so important in these times, especially. One of your many outstanding books is Standing at the Edge, Finding Freedom Where Fear and Courage Meet, and a personal favorite. And it talks about the very real challenges that physicians face in providing so much of themselves for patients that they slip over into burnout, compassion fatigue, moral distress, empathetic distress, and may ultimately lose interest in medicine. Roshi, how can you guide physicians into providing compassionate care while at the same time avoiding the edge into compassion fatigue?
Well, I think the book is useful in the sense that it really arose standing at the edge, finding freedom where fear and courage meet. It really rose again out of my personal experience, but also the experience that I've had with thousands of others in medicine, but also in corrections, in the political and corporate realm, human rights work, and so forth. And I identified these 6 edge states, and they were those edge states. There are actually many more, but they're the ones that most frequently were articulated, and they include altruism, empathy, integrity, respect, and engagement. And the shadow side of each of those experiences are pathological altruism, empathic distress. In integrity, it's moral suffering, respect, disrespect, and then engagement and burnout. And mapping those landscapes, as I endeavored to do it in the book, really, it was an exercise for me to actually look at what happens and how, when we go over the edge of altruism into pathological altruism, for example, what's the pivot? What can transform that experience? And I just want to do a parenthetical here, and that is actually, I really admire the work of Dr. Figley, but using compassion fatigue, to me and to Richie Davidson, Antoine Lutz, Tanya Singer, to a whole host of people in neuroscience and social psychology. Using that term, compassion fatigue, is highly problematic because actually what the experience is, according to the work in neuroscience, is not compassion fatigue, but empathic distress. It's over-identification with the suffering of another and the distress that results. And we know this from the work of Daniel Batson, Nancy Eisenberg, and other people in the field of social psychology. So I sort of want to address that, bowing to Dr. Figley, but also saying, no, that term actually is a misunderstanding of what compassion is and a conflation of compassion with empathy. Yeah. And what the research is very, very clear that compassion from the point of view of what in the field of neuroscience and my own work, what it is something that is in a certain way inviolable. In other words, it cannot be something that fatigues you, genuine compassion. And it is, in fact, the pivot point, the means wherein the toxic aspects of the edge states are transformed. And that was just, when I did the work, again, consulting with a lot of neuroscientists and social psychologists, excuse me for being colloquial, it blew my mind. And the book doesn't reflect a blown mind, hopefully, but it reflects the it reflects this perspective.
Yeah.
That the way that these toxic states of virtues, I mean, a world without altruism, you and I wouldn't be alive.
Sure.
Our parents would just have neglected us and let us, die. And from the point of view of social health, altruism is essential. Empathy is essential. A world without empathy is a world where we are dead to each other. Integrity is essential. That our character is rooted in our deepest values. And when our values are violated by ourselves or by the context of our experience, that's when moral suffering arises.
Yeah.
And so on and so forth. And the means of transformation, in fact, is the natural activation of compassion.
So thank you so much for that answer, Roshi. We've been discussing such deep topics here. I think compassion is one thing that we can talk about for a long time because it's such a beautiful human experience. One thing that we do here in our podcast, and is what we want to leave our audience with, is what we call a pebble. That one call to action, that one invitation, that one exercise that we can do, that if you throw that little pebble in the water, it's going to create ripples of wellness and compassion and peace. And we want to ask you, do you want to leave a pebble with us today?
I think a good pebble to leave is the pebble of practicing good self-stewardship. And what self-stewardship, which is a term that was coined by Cinder Rushton at Johns Hopkins, it's that experience that reflects values that are related to respect and care and responsibility, understanding and trust and compassion. And self-stewardship basically involves behaviors that are life-affirming in relation to one's own health and the well-being of one's own life, and also living a life of integrity and meaning. And I just want to share Cinda's words, because I think it's a very direct expression of a pebble that I work with every day, that I hope ripples in my personal life, but also in the lives of others. And Cinda said, self-stewardship embodies a commitment to know oneself and to responsibly and mindfully manage one's personal resources, and to recognize and compassionately respect one's limitations, and to choose actions that are wholesome and life-affirming. I really appreciate her words in relation to what so many of us encounter today, which is we are busy. There are high demands made of us. We are tipping into pathological altruism and burnout all of the time. And unless we understand the value of our own well-being, not in terms of, sort of narcissistic, victim-oriented self-care, like, oh, I'm not enough and I need to go to the spa. And actually, it would be probably good for me to go to the spa, but nonetheless. But, practicing this kind of awareness about what will really serve in making it possible for me to show up in a more transparent, more grounded and loving way in the midst of the suffering of this world.
Wow.
Yes,
Thank you,
so
Roshi.
beautiful.
I am taking that pebble and I'm going to use it myself. This one is one that I needed to hear. Thank you so much. And thank you, Jenny, for joining us. We need to have you another time and have a whole conversation about what you do, because you are also a wonderful, beautiful human being.
I was so honored to join this wonderful group. Thank you.
It's such an honor to be here in presence of you and Jenny, and we are just so grateful. Thank you.
Have a beautiful rest of your day. And Jenny, much love to you. And thank you both so much.
Ripple's Physicians Wellbeing is made possible by the Joe R. and Teresa Lozano Long School of Medicine Office for Graduate Medical Education. To contact us or learn more about the Wellness Home, visit gmewellness.utesca.edu.
This podcast is inspired by the Dalai Lama's powerful quote, "Just as ripples spread out when a single pebble is dropped into water, the actions of individuals can have far-reaching effects." We provide physicians with pebbles, tangible and actionable practices that can help make positive impacts in their personal and professional lives.